now we're going to talk about our cardiovascular system. Right. At this point, I think you guys should be experts at blood flow through the heart. You know, how the blood comes in. Do you want me to go through that, or that's something you guys feel you're comfortable with?
We're good.
You guys are good in terms of blood flow?
Yeah, we got
Right.
it. Yeah.
All right. So make sure you guys know, right, which part carries deoxygenated blood, which parts carries oxygenated blood, and the valves. So the valves, I'll go through this in the next slide, but make sure, right, I draw out the arrows, right? Hopefully you guys know this. If you want me to go through this, I actually had a video posted on Cardiology Review where I go through this in depth. So take a look at that. I'm not going to waste time again to go through that. So take a look at that video. But what you want to remember is the valves through it. A good mnemonic is tissue paper my assets, right? So this basically goes through the valves as the blood moves through the heart in a normal, right, physiology. So we have tricuspid, right, pulmonic, mitral, and aortic. So if you want to remember, you remember tissue paper my assets. And this is a good mnemonic, right, through the flow of the valves. The other stuff we're going to go through is the normal and abnormal heart sounds. So normal heart sounds is S1 and S2, right? That's what you hear lub-dub if you take a stethoscope and you put it mid-clavicular line, fifth intercostal space. What is S1, right? So it's closure of your mitral and tricuspid valves. Another name for them is AV valves, atrioventricular valves. And then what is S2? S2 is the closure of your aortic and the pulmonic valves, right? And we call them the semi-lunar valves. So that's the normal, right, lub-dub. Then we have here they show you opening snap. So usually when the valves open, they should not make any sound. I was giving you this question, right? So the closure of normal valves gives you S1, S2, but the opening should not give you a sound. If it does, that's abnormal, right? So maybe it's a stenotic valve, right? So that's what we can auscultate. S3 is usually indicative of rapid ventricular filling, usually indicative of patients who have congestive heart failure. And then S4, it's atria contracting against the stiffened ventricle, right? So S3 and S4 are pathological sounds. They're usually not heard on healthy patients. So if you hear S3, S4, those patients have pathology. How would you hear these the best way? So the best way you could download, I know Littman had a program before where you could download these sounds and you could auscultate them. The other way you could do it, if you're doing interfacility transport and there's an echo report with the paperwork and it says, okay, the patient has a murmur or it has, abnormal sounds, it has S3 sound or S4 sound, so whatever the paperwork has, I would say, if you read it, then take a listen to the heart sounds. So that should also, give you some exposure to that. Same way if you're doing rotations in the ICU and you happen to, see that they did an echo and they say they found this murmur, right? Or this valve is stenotic or so forth, right? Listen to their heart sounds so that you have an idea what they're talking about. Any questions about heart sounds? All right. The next thing we talked about, right, is the impulse propagation, right, through the heart. By the way, you guys heard of this term called automaticity?
Yeah.
What it means for a cell to have automaticity?
Every cell in the heart has the ability to be its own pacemaker.
Okay, so but not every cell in the heart is able to.
It is one cell to get excited will be excite the other cell next to it, and so on and so on and so on.
Yeah. So let me say it. So what automaticity is? It's the ability of the cell to initiate its own impulse and to depolarize. And my next question is, which cells in our body can act as a pacemaker in the heart? So the cells that have the ability, right, to depolarize, right, and act as a pacemaker those cells have this inherent ability, right, to have automaticity. And then my next question is, which cells in our body have the capability of having this automaticity?
Is it the endocardium cells?
Which cells?
Endocardium?
Not the endocardium.
Yeah.
So let me say it like in a plain language. Automaticity, right? Those cells can generate their impulse, right? They can depolarize and act as a pacemaker for the heart. The other cells in the heart cannot do that. So what I'm saying is, not every cell has that ability. So my question is, which cells have that ability?
The myocytes. No.
Which ones?
The myocytes.
The myocytes. The myocytes means just heart cells. But what I'm saying is not
muscle
all heart.
cells. The myo whatever.
What I'm saying is all heart cells in the heart are called myocytes, and I'm saying not all heart cells have the capability of initiating their own impulse, have the capability of automaticity.
Purkinje fibers.
Okay, Purkinje is one. What else?
SA.
SA. Okay. What else? Right.
AV
AV.
node.
AV. Right. So these cells, the SA node, the AV node, and the Purkinje. Right. So if we're gonna do this in the other order, right? I guess 1, 2, 3. Right. These cells have the capability of automaticity. They could generate the impulse, and they can be acting as pacemakers. How do you guys know that, right? Remember when you were studying the cardiology? SA node usually 60 to 100, right? Let's say I take out the SA node. Let's say it's infarcted. What's the next one?
The AV.
AV, right? What's the rate?
40 to 60.
40 to 60, right? I take out the AV. AV no longer working. Which one is next?
Purkinje fibers.
Purkinje fibers.
Yeah, 20 to 40, right? So these cells have the capability of generating automaticity, their own impulse, and then they can, right, act as a pacemaker of the heart. The other cells, they do not. So how do they get their, their impulses? Through gap junctions, right? Remember we talked about there is gap junctions that allow cell-to-cell communication, right? So then the ions can propagate from cell to cell, right? And then these other cells can depolarize, but these cells, they set they're the pacemakers, right? And you will say, well, how come the SA node, right, is the pacemaker and AV node is the pacemaker and Purkinje? Why didn't they all, fire at the same time? So what happens is when this impulse from the SA node, if it's functional, comes to the AV node, it basically has what's known as demand inhibition. It inhibits the other node from becoming the pacemaker. So the fastest one, the SA node, right, sets the rate, and when the impulse comes, it inhibits this one from acting as a pacemaker and so forth. But the moment this is taking out, there's nothing inhibiting it. So there's no inhibition. So this one picks up as the next fastest and so forth, right? And how do they do that, right? How do these cells do that? So that's the next thing to explain for you guys. So here we see, right, the SA node is the pacemaker. We see this impulse propagating through the internodal pathways, right? And depolarizing the atria. Then it gets to the AV node. AV node is slow to depolarize. It holds the impulse for a few seconds so the ventricles can fill. And then this impulse propagates, right, through the bundle branches and the Purkinje fibers. And then we have the contraction of the ventricles, right? So here we see, right, SA node, depolarize the atria, right? Then it's going to depolarize the septum, right? 3 is going to go through the anterior septal region towards the apex, this being the apex, this being the base of the heart. And then, right, it's going to depolarize the ventricle, the bulk of it, right? And then as it propagates, right, it's going to go towards the base. So the base was up here of the heart. So this is how it propagates. And this is our propagation of, right, the signal. And we see that tracing on the EKG, right? The EKG is what basically shows the atrial activity, right? So from the SA node all the way up until the AV node, as the impulse is propagating, right, up until this point, we see this, we call it the PR interval, which is 0.12 to 0.20, right? And this is how the impulse gets to the AV node. And then we have the ventricular response as it goes through, right, through the bundle branches and the Purkinje fibers, and we see, right, the QRS. And then your ventricles have depolarized, right? And then the process is going to continue with, right, repolarization here with a T wave formation, right? And here we see, right, basically the EKG. You guys now know all the waves, P waves, Q waves, R wave, S and T. So not going to spend the time to explain all this. I think you guys are knowing all that now. And this is what I was going to get to, right? So this was the schematic we were drawing, right, for the cells. We see, right, that initially when these ions are coming in, we have depolarization, and then here we have the repolarization. And in this stage, we have something known as relative refractory period, meaning no impulse can trigger, right, the next depolarization until it goes back to the resting state, right? And then my question is this, right? Why are these cells that I was drawing earlier have this ability, right? This SA node, AV node, Purkinje, why do these cells have the ability to have automaticity and the other cells do not? Like let's say the atrial cells themselves or ventricular cells, they don't have that.
You have special cell called intercalated disc, which is like distinguish this cell from the other cell from the other heart cells.
But why? So my question is, why do these cells, like what's so special about these cells, SA node, AV node, Purkinje, what's so special about them that they have this, inherent property?
Does it have something to do with the pathways?
It does, but can you be specific? What exactly?
They're insulated. I don't know.
What is it? Sai, did you say insulin?
No, he said they insulate.
They're insulated. I don't know.
Oh, insulate. Okay, I heard insulin. All right, so I will explain to you, right? So here, right, you see this graphic, right, how it goes through -90. But when you look, right, when you look at these cells, like for example, for the SA node, you see how their slope is bigger like this. Their slope doesn't start like that, like it will be on the ventricular cell, like you saw here, right? See how the slope is flat? These cells here, they have an elevation. So what this means is this, right? They have the capability of having leaky channels, right, that will have the slope for them. So both, SA node, AV node, and the Purkinje all have this slope. And the difference is this: the degree of elevation of the slope differs from SA node to the AV node to the Purkinje. So SA node may be this, the AV node may be a slower slope, and the Purkinje is like this. So the time frame it takes to reach threshold is longer, right? You see that? Right? And the other cells, right, that let's say the atrial cells themselves or the ventricular cells, they don't have the slope. They utilize the impulse coming in with use of these GEM junctions for ions to trickle through cell to cell. When the SA node, AV node, and the Purkinje sets the slope, right? So this is how we work. We see, right, in the setting of sympathetic stimulation, right? Let's say you have high epi or norepi release. We see how these impulses come in faster. So they come in one after the other. In the setting of the parasympathetic stimulation, they're slower, right? Because the acetylcholine acting on M2 receptors, and it will slow it down. What else do you see, right, in the parasympathetic stimulation? There's something else about this graph it's kind of like, it's hard to see when you look at it. But what you see, right, you see how in the parasympathetic, it lowers this versus here, right? So the resting state of the cell, right, before it was -60 here, for example. See how it lowered it? So you have a longer ways to go until you reach threshold. So the parasympathetic system under stimulation of acetylcholine will do that. right? It will lower your threshold. In the setting of norepi, see how it increased? So increased the resting state so that it's much faster to reach the threshold, right? So just to compare from your normal, right, where the resting was 60, in the setting of the parasympathetic, it lowered it. In the setting of sympathetic, it increased it. So the threshold is achieved faster. Now, why do you think, well, let me say it again so you guys can understand. Why do you think this is kind of like important that I'm spending so much time here to show you this?
Because it's going to be on the final.
It's going to be, I'm not going to be, well, there's going to be questions on this, but there's even a more important reason why I'm showing you this.
Because it's the most important part of our job.
But do you know why, James? It is. But do you know why?
For choosing of the treatment of the patient itself.
For which drugs? For which drugs?
For epinephrine and
for the antidysrhythmics drugs.
Who's saying antidysrhythmics?
Myquan.
Excellent.
And James.
And James, right?
James ain't saying nothing.
Myquan, you are 100% on it, and I will show you here, right? So let me show you the normal, right? So we have different antiarrhythmics, right? We have sodium blockers like lidocaine. We have potassium blockers like amiodarone. We have calcium blockers like diltiazem, right? There's beta blockers you do not carry, but given in the hospital. So what these drugs do? So let me just go through the types of responses they do, right? So you guys kind of have an idea. So one drug I can give you, right, is this. I can lower this resting state, right? So I can take it from -70, let's say, to -90. I can give you a drug. I can give you a drug that does this. Let me just make
Andrew,
sure.
I think your mic is
Andrew, your mic is on, bro.
I got it. I will fix it in a second. I got it. All right. So one drug you could give is to lower this resting, right? Another drug I can give you is elevate the threshold. So instead of make it -30, I could make it maybe -20. I can do this. Another drug I can give you is that I can increase this slope to go like that. Right? So let's say this is drug 1, this is drug 2, this is drug 3, and another drug I can give you, I can also decrease this, could make it like this. So 1, 2, 3, and 4. So the drugs that will do number 2, raise the threshold potential and lower this slope, is calcium channel blockers, and sodium channel blockers like lidocaine and diltiazem. Right? The drugs that lower your threshold like this is adenosine that will lower this. Your potassium blockers like amiodarone will increase this, right? They'll take the cells longer to depolarize. So they will increase the QT interval, right? That's why we don't give the amiodarone in the setting of prolonged QT interval. It may cause torsades. And then beta blockers, right? Their job is basically number 4. They will lower the slope. So overall, right, the goal is this, right? We're giving you different drugs that target different locations in the heart, right, to adjust the rate of firing of your cells. So for example, let's say I gave you're having a tachycardia, right? You see here, sympathetic response. So you have a SVT, right? Supraventricular tachycardia. So imagine these are even more frequent. They're like this, right? So you have an SVT going. So an SVT, right? Let's say you can call, right? And you could give, well, you don't have to call for it, but you could give them adenosine, right? The adenosine is going to lower this. So it'll take longer. And then the other drug we could try to give this patient is calcium channel blocker. And the way calcium channel blocker work, I just said, it will increase the threshold and it will lower the slope. So it will look like this until they reach. So this will slow down, right, the heart. So depending on what you want to do, right, you could adjust your drugs, right? And remember I said also, right, in the SA node, AV node were calcium channel depolarization, but Purkinje system was sodium channel. So let's say you have ventricular tachycardia, right? You're thinking maybe, right, the origin may be Purkinje system or the ventricles. That's why we are thinking, right, maybe we'll give them lidocaine, sodium channel. If it's supraventricular tachycardia, like SA node, AV node, why we give them calcium channel blockers, right? Because calcium is what's predominantly depolarizing these cells. So it kind of makes sense, right? So we see this here, right? So this is the graphic. Here we see the parasympathetic, right? How it lowered. Similar function with adenosine, right? Here we see sympathetic stimulation where it raised it, right? More rapid depolarization. And so this governs, right? Normal heart rate, tachycardia, bradycardia, basically these responses, right? I just want to show you, this was the chart before I get through all this, so you guys can see here, right? So here they show you SA node, AV node, Purkinje, right? And you see the principal cell that's responsible for depolarization. So what you see for the SA node, AV node, predominantly it's the calcium, right? What do you see for the Purkinje and the ventricular cells, right? And the atrial muscle, we see particularly, right, these are the sodium, right? So whenever we target like SVTs, for example, that's why we consider giving them calcium channel blockers for these reasons. We target the ventricles, right? We see VTAC, right? Maybe we'll give them lidocaine, right? And then amiodarone, right, as you guys know, right, even though I said it's a potassium blocker, has multi-effects. It blocks a lot of receptors, right? So it's a multi-effect drug. That's why we could give it for supraventricular tachycardia. We could give it for ventricular tachycardia. It has a lot of blocking properties. It's not like just a single channel blocker, right? Hopefully that's clear. Any questions about this? I'm not going to have questions on like what I drew just now. I just wanted to explain this. I think it's important for you guys to know, especially with doing these mega codes, cardiac arrests, right? We're giving antiarrhythmic medications. So you guys have an idea how it works. All right. No questions? The other stuff we're going to go through is these terms, right? Preload, afterload, right? All of that, right? So what is preload? Preload is everything that's coming into your ventricles before it contracts. And as you guys know about the Frank-Starling's law, the bigger, right, the stretch, the stronger the contraction, certainly up to a point. But preload is what bringing that blood in, causing that stretch, right? And the bigger the stretch, the bigger the contraction is the Frank-Starling's law. Afterload is all the forces that the ventricle has to overcome in order to eject the blood out, right? So if you have, let's say, blood pressure of 200 over 100, the left ventricle has to overcome the 200 systolic in order to eject the blood, right? And this is like the clamping down, the afterload here you see, right? Right. So preload, where is it coming from? It's coming from your capacitance vessels, right? Your superior inferior vena cava, we call it the tank, right? And then, right, what happens is, right, it fills the ventricles, right, as the preload is entering the right heart, the right atrium, and then it's filling the left heart, the right ventricle, and the blood moves forward. So everything that's coming into your ventricle with ventricular filling, right, it's called the preload. And your heart, the pump, right, then works on that preload to contract with inotropy, right? And it contracts, and then the blood gets ejected. It gets ejected, and it must overcome this afterload in order to pump the blood systemically, right? And so then we can see, right? So preload, right, is all the blood that's coming in. Afterload is the forces, right? And inotropy is basically the pump, right? And I wanted to show you something, right? Remember we were drawing out the formula, cardiac output equals heart rate times stroke volume. So this component of it, right, which is roughly about 70 ml, it's dependent on, right, preload afterload, and contractility, or another name is inotropy. So I'm just going to write contractility to make it simple. So here you could see, right, heart rate, right, what dictates the heart rate could be your sympathetic and your parasympathetic system. Sympathetic increases, parasympathetic decreases. But what determines your stroke volume, right, the 70 ml, is preload, how much of it is coming in, right? How much is the afterload, or systemic vascular resistance, and how much your heart contracts, right? And so I could give an example for every single one of them. Let's say you got someone with a massive heart attack, right? And their pump is affected. So their contractility is down, right? And then you understand that, right? The pump is not pumping so well. So if contractility is down, your stroke volume goes down, right? Give you another example, right? You have a patient who now sustained massive heart attack with right ventricular involvement, right? They have right RV involvement. You did the right side EKG, right involvement. You go ahead, you give this guy some nitrates. You drop their preload. Do you think their stroke volume will be good? No, the stroke volume is going to be very, very bad, right? Now, you have a patient, right? You're trying to bring up their blood pressure, right? You assess them, right? And you notice, right, their diastolic blood pressure is low, right? They're like 70 over 40, let's say. So that means their afterload is poor, right? They have poor peripheral resistance. A lot of time you see that in septic patients, right? So this is why we get those pressors on board that increase systemic vascular resistance, right? So basically, the stroke volume is governed under preload, afterload, and contractility. In other words, is inotropy. Heart rate is governed by your sympathetic and the parasympathetic division, right? Together, they increase your cardiac output. Right? Any questions about this one? All right. This slide was basically everything I just explained to you, right? So heart rate of this formula is governed by your autonomic nervous system, and this part, right, of the stroke volume, right? The stroke volume is governed by the factors that I just explained to you, right? So which was the preload, right? Which was the contractility, right? And it was the afterload. So here they make it a little complicated with these arrows, but bottom line is it's this. If you understand this, right, I think you're in a good shape in terms of what's affecting the stroke volume, what's affecting the heart rate, and how they impact the cardiac output together. Right? Here is just to show you, you have about, let's say, 5 to 6 liters as your cardiac output, as we talked about earlier. And here they show you roughly how much of the blood goes to which organ, right, at the rest. So say at rest, we specifically talked about the kidney. I told you it was about 1 liter. Remember when I was telling you about the glomerular filtration rate? About here they show you 1.1 liter, right? And you see how much of perfusion is going to which organs, right? In light exercise, what do you see, right? So in a state of light exercise, more blood is going to your muscles, right? And we see that here, right? And where do you get it? Maybe you divert some of it from other locations, right? And here they show you heavy exercise, right? A lot more blood is going to your muscles because your muscles requiring. In a state of shock, right? Somebody's going into the state of shock. We want to make sure that the blood flow to these organs is preserved, right? So that's why if you're in ICU, they're constantly checking urine output, right? So they make sure that the kidney is getting enough blood flow. They're constantly checking. You constantly want to check, right, your neuro status. You want to check your cardiovascular status. How do you do that, right? Maybe we put an A line checking their, pressures, checking their mental status with assessments, checking their kidney perfusion with the renal, with the Foley catheter, right? How much blood is being made, right? And what you will see is that in the shock states, right? Why do you have cold skin, right? Cyanosis, right? Cold clammy extremities is because the body is going to divert, it's going to vasoconstrict to basically take all this blood that's here and move it to the vital organs, right? To perfuse the brain, the heart, the kidneys, right? And that's what we observe. Here shows you, right, the blood pressure that you find in different locations. So normal blood pressure, let's say 120/80, right? And we see that right in the aorta, right? Your systolic and your diastolic pressures. And then as you go down, right, towards the veins, the blood pressure drops significantly, especially in your vena cava, pressure being 3, your right atrial pressure maybe 2, right? And it makes sense because blood flow is from high to low. So we want, right, the blood to flow to the veins so that then it can come in. The capillaries have also lower pressure. They have high cross-sectional area. This is where the blood is exchanged, right, with the organ systems. So as you go from the arteries, right, to the capillaries to the veins, your blood pressure is decreasing. Your pulmonary circulation, right, we have the pulmonary artery. You notice how much less of a pressure it is in your pulmonary system, right? Your pulmonary pressure here, they show you, right, pulmonary artery, maybe your pressure is like 25/10, right? And it makes sense because the pulmonary circuit is not as extensive as your systemic circuit, and you don't have to generate such high pressures to pump the blood to your lungs. But your left side of the heart is much bigger. Why? Because it's pumping systemically, so it has to pump through a higher pressure. That's why it's usually bigger in size, right, for all these reasons. And then something, right, we talked about is basically your mean arterial pressures. It's basically the pressure under the curve, right? And we calculate that with the formulas I'm going to show you in a second, right? So mean arterial pressure is the mean pressure in your arterial system. It's the pressure under the curve. So let me see if I actually, yeah. So I'll just write the formulas here for you to do it. So there's 2 different formulas for calculating mean arterial pressure. One of them, you could use 1/3, right, of your pulse pressure, which is systolic blood pressure minus diastolic blood pressure, plus the diastolic blood pressure. But this is known as the pulse pressure, this portion. And the other formula is 2 times diastolic blood pressure plus systolic blood pressure divided by 3. So all of these are the way to calculate your mean arterial pressure. You could use whichever formula you prefer, right, to calculate it. Maybe one is easier than the other. I will say I do recall questions on some exams that did not ask you to calculate it, but they asked which of these formulas will calculate the mean arterial pressure. So my advice to you is to know both of them, because you know, you may be asked for the formula, and if you don't know this, you know what you're going to be doing? You're going to be trying to figure out, like, you'll start plugging in numbers like maybe 120/80 into each formula, trying to see if you get the correct map, which you don't want to do. So my advice to you, make flashcards, remember both of these, right? Try to go through them. We talk about map of 65 is our goal, right? Greater or equal to 65 millimeters of mercury. Can anybody tell me why we want a map of 65?
That's what you need to perfuse the brain and other vital organs.
And the heart, yeah. Map of 65. Yeah, you need that to perfuse your heart and your brain. Enough pressure to basically have the blood flow to do that, right? What else is important here? Do you guys want me to actually do the calculations, or you guys are all right with the formula?
We're good.
You guys are good? Okay. And you want not sure how to calculate map at all? Anyone sitting here has no idea how to do map? You could speak up now. Otherwise, I will leave these formulas for you guys I think I did it several examples in the other lectures. So you may have a question, which is the formula, or maybe calculate the map. So make sure you know how to use the formula and what are the formulas here. So this is formula 1, this is formula 2. Right? Since nobody wants me to do that, I'm gonna go forward. The other things that is good to understand, right, is how do we calculate the stroke volume? So the stroke volume is calculated. We take the end diastolic volume, right, the amount of volume that's coming in with the preload, subtracting the end systolic volume, right, how much is ejected how much is left after the contraction. So how much came in and how much remained. So this is end systolic volume, this is end diastolic volume. So how much remained after the contraction. So what came in, 120 ml, this is end diastolic volume. After the contraction, right, how much remained? This is end systolic volume, 50 ml. 120 minus 50 is 70 ml, which is our stroke volume. And then we have something known as the ejection fraction, right? What is the ejection fraction? We take our stroke volume, here let's say 70 ml, and divide by 120, right? Which is the end diastolic volume, and here they tell you, right, 55%. To make it simpler so you guys can see it, let's just say your stroke volume is 70 ml and your end diastolic is 140 ml, right? So here, if we do this, right, 7 divided by 14 is 1/2. So 1/2 is 50%, right? This is how they get it. So this is your ejection fraction. Why did they look at the ejection fraction? If your ejection fraction drops below a certain number, you may be a candidate, right, for either a heart transplant, or here they show you left ventricular ejection fraction going lower. Maybe be a candidate for LVAD. You guys know what LVAD is?
Left ventricular assisted device.
And what does it do?
It takes the place of the left ventricle because it's not able to pump properly.
So, right. So what happens is basically they put a device. It's like a slow current motor, and it's going to siphon blood from the ventricle because it's not contracting into the aorta in order to help with the cardiac output. So the takeaways from this one is this. Stroke volume is the volume that's ejected with every contraction. How do we calculate it? We take end diastolic volume, the amount that blood came in, and then after the contraction, we see how much remained. That's called end systolic volume. We subtract the two, we get the stroke volume. And then if we take how much was ejected, which is the stroke volume, over how much came in, and diastolic volume, we can develop something known as the ejection fraction. Roughly speaking, right, for an adult person, 50% is healthy. And here we see the calculation. Right? And any questions about this? All right. And this was the ions that we talked about, right? SA node, AV node. What depolarizes that? It's the calcium channels. Purkinje system is the sodium channels. Right. The next thing we talked about, I think, was the in the chapter of MI, right? What happens is we have these platelet plugs. We have the platelet aggregation factors that's coming in, that's forming the clot, right? This happens at the damaged vessel wall. That's a normal response. When we let's say you cut a finger, right? You want the vessel to clot, but if it happens in the coronary artery, this is when the flow is impacted, right? So here we see something, right? The clot formation. So you guys remember I was in the renal chapter, right? I was talking about angiotensinogen, and here, right, we have fibrinogen. So what's so special about these GEN? You guys remember? What's so special about this one? You have fibrinogen, you have angiotensinogen, you have pepsinogen.
Something to do with the proteins?
Yeah, but what specifically?
Binds?
So when you see GEN, it's usually inactive form, right? They're not active. We call them zymogens. So when you see like anything with GEN ending, fibrinogen, angiotensinogen, right, pepsinogen, they're inactive. They need to bind to something to activate them, right? So here we see thrombin, right, comes here with fibrinogen, and then basically then takes fibrinogen into the fibrin, and that is, right, when you have the active products, they can actually form the clot. So fibrinogen is inactive. Once it's activated, it becomes fibrin, which is active. So GEN ending inactive form. Right, so clot formation, right? And where we worried about this is basically in the coronary arteries, right? So we see the coronary arteries here. They coming off the aortic ostia, this one and this one, right? This is the right coronary artery, and this is the left coronary artery that's coming here, right? The right coronary artery is usually, as you can see, right, feeds the right atrium, the right ventricle, the SI node, the AV node, right? The left coronary artery feeds the left ventricle and the lateral wall of the left ventricle. You see how there's two? This being the circumflex, and this is the LAD. This is the right coronary, right? So depending on where the clot is, we can perhaps see that on the 12-lead EKG and say, okay, this is the inferior wall, this is anterior wall, this is the septal wall, this is, right, the lateral wall of the heart, depending on the elevations. So we roughly can say where the blockage may be. You truly don't know it until you take the guy to the cath lab and they open up and they take a look, right? Because the inferior wall, right, you see, inferior wall can be fed by the right coronary artery, right, as it comes here, but also you see how the circumflex go in the back. So the circumflex can also feed the inferior wall of the heart. So you got to be careful, right, when you are saying, right, inferior wall is only by the RCA. Sometimes patients may have the circumflex that's feeding the inferior wall. And usually, right, remember, if you guys remember, there's something good to remember. In lead, if you have lead 3, the ST segment elevations, right, are higher than lead 2. That's usually, so means this elevation is higher than lead 2. That's usually indicative the involvement is the right coronary artery. So something you want to pay attention to. So next time you're looking at the inferior wall, if lead 3 has higher level ST segment elevations than lead 2, you're probably dealing with RCA involvement. All right. Let's see what else about the cardiac chapter. So we talked about the impulse propagation. We talked about the channels. We talked about the blood flow, which you guys should know, the different coronary arteries and which part of the heart they feed. We talked about the mean arterial pressures, the formulas. We talked about the formulas of heart rate times stroke volume. Oh, there's something else, right, that I wanted to make sure, right? So we said cardiac output was heart rate times stroke volume, and the formula for the blood pressure was cardiac output times systemic vascular resistance. And the cardiac output, as I said, was made up of heart rate times stroke volume, right? So in terms of your blood pressure, right, if you cannot increase the blood pressure after you corrected the heart rate, right, and you gave them some fluids, right, the problem is probably now with this portion, right, systemic vascular resistance means it's not adequate enough. So this is when we have to onboard pressors. We got to give them pressors to get this number up so that the blood pressure elevates. Right, make sure you don't confuse this formula with your MAP. This is not MAP. Right, so mean arterial pressure is the average pressure, right, that we're calculating, which was the other two formulas here that I have, right? So MAP is these formulas. If you ask to calculate MAP or what's the formula, it's this formula. If you're asked, if you're showing this formula for blood pressure, this is not MAP. This is has relationship with cardiac output with systemic vascular resistance. Okay. Any questions about that? No questions? Okay. So the next chapter I think we're going to go through is we start with the cells, right? We're going to do a brief review of your immune system and the immune system cells. So the cells that we just talked about earlier, right here, these were thrombocytes, right, that come in, right? This is your platelets when we're dealing with your immune system, right? We're not dealing with platelets, right? And we're not dealing with red blood cells, which were erythrocytes, which we went over with, right, oxygen transport and CO2 transport. So when we're dealing with your immune system response, we're dealing with white blood cells, right? The white blood cells that we have here, right, is the monocytes, lymphocytes. We have the neutrophils, eosinophils, and basophils. You guys remember mnemonic, how to remember all of them?
No.
So a good mnemonic, if you want to remember all the white cells, it's never let monkeys eat bananas, right? So neutrophils, lymphocytes, monocytes, eosinophils, basophils, right? So if you want to remember all of them, never let monkeys eat bananas, right? Neutrophils, lymphocytes, monocytes, eosinophils, basophils. Good? All right. Here they show you, right, the formation. We talked about granulocytes, right? They have specific granules, which were neutrophils, eosinophils, and basophils. So they're granular cytes. And then we have agranulocytes, which were monocytes and lymphocytes. Not that these cells do not have granules, is that they don't have specific, granules like these cells, but all of them have granules, right? But so if the question asks, what are the granulocytes? The answer is neutrophils, eosinophils, and basophils. See how they end in phils? And then when you see cytes, these are agranular cytes. Okay. So let's talk about some of the functions. So here we see, right, again, granular cytes being these cells, right, neutrophils, eosinophils, basophils. Let's talk about the functions, right? So we see neutrophils, they're multilobated. And what you want to remember, the first cell that comes to the site of the injury when you have, let's say, an acute infection is neutrophil. That's the first one to come. What it's going to do, right, it's going to be the big eater. It's going to phagocytize, right? It's going to phagocytize the pathogen or the bacteria or whatever the foreign invader may be, right? And the goal is basically to fight the infection. First line of defense in terms of the white cells, right? That come into the site of the injury once the pathogen enters the bloodstream. So if we do a blood work, right, we expect a lot of neutrophils in your blood, right? And we know maybe the person is having an infection, increased white count, increased neutrophils. So first line of neutrophils that come in. Then we have eosinophils, right? So when do you see eosinophils? A lot of times we see this increased in a parasitic infection like ringworms, right, or anything like that. We also see this increased in setting of an allergic reaction. So allergic reaction. So eosinophils get elevated with allergies and the parasitic infection. Then we have basophils. A lot of times we see this in your anaphylaxis and allergic reactions, and they release something known as histamine, right? When they break up, they release histamine. And this is what, we see a lot of times, those patients who have allergic reaction, and histamine is responsible for a lot of the permeability in the smooth, in the vasculature, right? And you will see that vasodilation occurring. They start to develop urticaria and stuff like this, right? With degranulation of basophils. So what you want to remember, neutrophil, primary white site when you have early infection, such a bacterial infection, their job is to engulf and phagocytize the bacteria. Eosinophils, right? When do you see them? When you have parasites and you have allergic reaction. Basophils, a lot of times it's type 1 hypersensitivity reaction, which is massive allergic reaction or anaphylaxis. And then the other sites we talked about were agranular sites, right? And this is the monocytes and lymphocytes, right? So what are monocytes? Monocytes are the white cells that are found in your circulation. The moment they leave the circulation, they're called macrophages, right? Macrophages, or big eaters. Their job is to basically engulf the pathogen, but unlike just the neutrophils, they are also antigen-presenting cells. So what they can do is, after they engulf the pathogen, they can present this to the immune headquarters and say, listen, we got this new pathogen that's came in. We would like to make antibodies against it. So that they're antigen-presenting cells, and then they're going to help with the assistance, right, of these lymphocytes. They will help to make more antibodies, right? So here we have now lymphocytes. These are made, right, in your body. Usually we see a lot of these, they say here, right, they start to circulate, they're produced in the bone marrow and they go into the lymphatic tissues. We see a lot of times they start to elevate with long-term chronic infections, right? And so they will be elevated. So let me show you some things in terms of the body's response, right? So here we see the lymphocytes, right? The cells here, right? The lymphocytes. And they're broken down into the T cells, right? Which are made in the bone marrow, but mature in the thymus, the thymus tissue, right? The lymphatic tissue. Then we have the B cells, which basically help us with formation of these antibodies. And then we have the natural killer cells that are always there patrolling, right? Looking for like any abnormal tumors or abnormal cell growth, right? Abnormal proliferation, right? So that the cancer doesn't, continue spreading. So they arrest that process before it progresses, right? So lymphocytes, right? Here, these are the cells. The T cells, right? Mature in the thymus, and then we have B cells and the natural killer cells. So now, to show you, right? So all of them are made in the bone marrow, right? These go into, after they're made in the bone marrow, right? These go into the thymus to mature. And now we have this differentiated T cells, and then the lymphoid cells here, right? Further subdivide into the B cells and the natural killer cells. Natural killer cells' job is the surveillance, right? They're always looking for that abnormal differentiated cells to attack them and kill them. And then the B cells, they basically, that's what they're going to make the antibodies, right, against, pathogens to help fight. And the example I gave, I think, to kind of illustrate it all, it's the type 1 hypersensitivity reaction. And I was using Ian as an example. I said he went to the barbecue, right? And unfortunately for him, right, he had these pollen grains that came in, right? These allergens. Ian, you remember, or yes, no?
Yeah. Uh-huh.
Right. So let's say you went to this barbecue.
I remember.
The first time you went there, you inhaled these pollen grains, right? You inhaled them, but for the first exposure, he didn't have any problems. So what happens is these antigens came in, right? They bound to the macrophage, tried to phagocytize them. And what it did was it presented to this antigen-presenting cell, and with T cell helper cell, what happens is it activated these B cells, and it said, okay, we see these allergens, right? We see these spikes, which are called antigens. And what we're going to do is we're going to form specific antibodies against them. So what it does is it makes a lot of Ig antibodies, which then are going to go find these basophils, and they're going to attach on the surface. So now after the first exposure, Ian did not suffer any problems, right? And, but when he was with his family, right? Sorry about that. He did not have any problems. And so he did not show any exposure. But on a second time, he went to the same barbecue, but this time he brought all of you guys to celebrate graduated the paramedic program, right? But now what the problem is now he has already built these Ig antibodies, right? Through the helper cells and the B cell activation. And now the same antigen, the same pollen grain came in. So this pollen grain comes in, but what did I say? his basophils, right, and the mast cells, right, are now preloaded with these Ig antibodies. There's a lot of them there, right? Shows here, right? Ig antibodies. So sensitization of the mast cells and basophils. So they're now preloaded. This antigen comes in, and what's going to do is going to degranulate. They're going to degranulate, and it's going to release all the contents of the basophils and the mast cells there. And the release of these has histamines, leukotrienes, right, and other chemicals. And what do? Is they cause all these systemic events, right? So we see in an allergic reaction, right, we see inflammation, we see pain, itching, we see urticaria, hives formation, right? We see with breathing, this also occurs, right, because they're lying in your respiratory tracts, right? We see bronchoconstriction, we see permeability on the vessels with the histamine. So there is edema formation, right? So you have hard time breathing. And the moment, right, you have anything impacting your respiratory system, we basically say, right, this is anaphylaxis, right? Airway constriction, edema formation, bronchoconstriction. So this is a dire emergency where we have to basically intervene, right? We know about epinephrine, right, to administer, right, for these patients. And how does epinephrine work? So it's the reversal, right? You're going to cause vasoconstriction. You're going to work on beta-2 to bronchodilate them, right? And so this helps with elevating their blood pressure, helps with, helping them breathe. And that's our goal, right, in this event. So in a nutshell, right, what basically happened is these allergens came in, and instead of the macrophage to engulf them and break them apart, right, to phagocytize them, it did something stupid, right? It said, okay, let me put them on the surface and take them to the immune headquarters, and it's going to take it to these B cells and say, listen, we got these allergens with these spikes, which are called antigens, right? And I want you to start making antibodies against them because we think this is foreign, this is bad for us. So it starts to make all these IgE antibodies, which are now loaded on the mast cells, right, and the basophils, which are lined all over our body, specifically the skin, your respiratory passages, right, and your blood vessels. So if I come in with this allergen again, and we know these mast cells and basophils are lining the skin, they're lining the respiratory passages, and they're lining the vessels, right, and they degranulate, I'm going to see urticaria on the skin and itching and hives formation. I'm going to see bronchospasm. I'm going to have edema formation, right, in the respiratory passages. I'm going to have vasodilation on my arterial side. And so the patients with this signs and symptoms, right, you're going to see, right, difficulty breathing, wheezing, urticaria, and low blood pressure, hypotension. So hopefully that makes sense now, right? And this is the effects. And you guys know about, right, the treatment modalities for that.